everyone. I'm Gladys Pryor, co-director of the Office of Community Engagement and Equity for the Department of Molecular and Human Genetics at Baylor College of Medicine here in Houston. This is the 18th anniversary of the Evenings with Genetics program, a free series open to the public. Evenings with Genetics was organized by Susan Fernbach, a genetic nurse and assistant professor in the department, recently retired. She was empathetic to the families and patients who had a desire to learn more about their conditions. During the month of February, we are recognizing and celebrating Black History Month at the 5th annual Evenings with Genetics webinar on Race and Genetics, Perspectives on Precision Medicine. Due to the ongoing social issues in our country, we felt there remains a need to address the old concepts of genetics and race to discuss some of the causes of health inequities and inequalities and enable us to improve access and care for people in all of our communities. During the webinar, you can enter questions in the Q&A box at the bottom of your screen. Dr. Deborah Murray, Associate Professor, will moderate the discussion and questions. Dr. Murray?
Hi, good afternoon, everyone. We have a great evening planned with three exciting speakers, Dr. Betty Pace and Dr. Sodeke and Alice Solomon. I will introduce each of them briefly here. Dr. Betty Pace is a professor in the Department of Pediatrics and Francis J. Tedesco Distinguished Chair of Pediatric Hematology Oncology in the Medical College of Georgia School of Medicine, Augusta University. Dr. Pace received her MD degree and residency training in pediatrics at the Medical College of Wisconsin and subsequent pediatric hematology oncology fellowship was completed at the University of Colorado Health Sciences Center in 1990. After serving on the faculty at the University of South Alabama and the University of Texas, Dallas, then Dr. Pace joined the faculty at Augusta University. As a physician scientist, she provides leadership for an NIH-funded basic translational research laboratory focused on the drug discovery for the treatment of sickle cell disease. In addition to research, Dr. Pace has personally trained over 100 scientists in her laboratory, and she directs an NHLBI-funded training program to increase diversity for individuals engaged in health-related research, functional and translational genomics, PRIDE FTG. Over 114 junior faculty members have completed the PRIDE FTG program to expand diversity of the U.S. biomedical science workforce. Dr. Pace received the Leadership in Promoting Diversity Honorific Award from the American Society of Hematology in 2017 for her mentoring contributions. Recently, she received the 2023 Woman in Science from the American Medical Women's Association for her research and training accomplishments. Our second speaker is Dr. Sodeke. He's a resident bioethicist and professor of bioethics and allied health sciences at the Tuskegee University Center for Biomedical Research. He currently chairs the Tuskegee University Institutional Review Board and serves as a bioethicist for the Alabama Genomic Health Initiative and for the Southern All of Us Research Network. Additionally, he serves as resource expert for NGO Bioethics Beyond Borders. At various periods during the past 20 years, Dr. Sodeke has served as Associate Director and Interim Director of the Tuskegee University National Center for Bioethics and Research and Healthcare. He holds a Doctor of Bioethics degree from Loyola University of Chicago, a PhD in Curriculum and Instruction in Allied Health Education, Supervision, and Administration from the University of Florida, a master's degree in Clinical Laboratory Science Education and Guidance from Texas Christian University, and in Bioethics and Health Policy from Loyola University of Chicago. Dr. Sodeke holds certifications in bioethics from the Kennedy Institute of Ethics at Georgetown University as well as in healthcare ethics from the University of Washington in Seattle. He participates in ethics consultations and speaking engagements that promote the goals and purposes of bioethics in medical, biomedical, and behavioral research locally, nationally, and internationally. His research interest areas are community bioethics, research ethics, healthcare ethics, gene ethics, neuroethics, health and human rights, community engagement and empowerment, ethical issues in clinical trials, health disparities, and research with vulnerable populations worldwide. And our third speaker is Alice Simon. I'm sorry, Solomon. She's a PhD candidate in molecular medicine at the University of Arizona. Born to Nigerian parents, Alice was raised in Houston, Texas, until she left to pursue her PhD in Arizona. Outside of school and work, she loves being creative whenever she has the time. If she's not working in the lab or doing experiments, she's making science-themed jewelry for her Etsy shop, listening to music, or watching TV to de-stress. She also loves cooking, baking, and trying new recipes to share with friends. Despite struggling with sickle cell all her life, she's thankful to God for how far she's come. So get yourselves ready for our first speaker, Dr. Pace. Yes, we can see it.
Okay. So thank you all for being here this evening to share our evening of genetics with this very special program looking at gene therapy for sickle cell disease. So I'd like to start by just saying, where did sickle cell disease come from? With the new approaches in genetics, they have been able to recently to actually trace the first person who had sickle cell disease to a child in Africa. That was the origin of it. And so why would we have the need for the mutation? Well, it helps to protect against malaria. Malaria is a serious infection around the world. And if you have one gene for sickle cell disease, you're protected. And of course, two genes, you have sickle cell anemia. So this mutation leads to a lot of other medical problems if you have two. But the whole point of this is that you have survival of the fittest with those people who have just one gene mutation. In 2010, we celebrated 100 years of history from identifying the first case of sickle cell anemia that was published in the United States by Dr. James Herrick, a graduate student who was in Chicago. And this is actually a picture of his blood cell smear showing the sickle cells on the smear. And so we've come a long way, made a lot of progress, but there's still things that need to be addressed related to sickle cell disease. Where is sickle cell disease distributed? This is a map showing by country, where you can see the very dark colored is the highest prevalence, mainly in sub-Saharan Africa and in India. And then we have medium range prevalence in the United States and Brazil. Over 200 people, 2 million, people are affected with sickle cell disease worldwide, and about 300,000 babies are born in Africa each year. And unfortunately, up to 90% can actually die by the time of the 5th birthday. So there's a great need for better research to improve the survival in low-income countries. What is a mutation? Just briefly, this is a cartoon showing the DNA bases that hold the building blocks of life, and these code for the building block of protein that are in our body. So there's a mutation at the 6th position of the human beta globin gene. This letter T has been mutated to a letter A, one single point mutation. The result of that is the normal building block glutamic acid is replaced by another one called valine. That leads to an abnormal interaction of the hemoglobin protein in the red blood cell, forming fibers, and the sickle cell, which lead to the clinical complications and manifestations we see in sickle cell disease. What about the inheritance? If both parents carry the sickle cell trait, that is one sickle cell gene and one normal, then with each pregnancy, There is a 1 out of 4 chance of having a child with no sickle cell trait or any abnormality. 2 out of 4 chance, or 50%, of having a child with sickle cell trait. And then 25% chance of having a child affected with sickle cell anemia. And what's important about this whole odds ratio thing is that it doesn't mean once you have one child, you won't have any more. It means with each pregnancy, these same odds apply. And we've had families that have 4 or 5 children with sickle cell disease, all from the same parent. So just keep that in mind. In the United States, newborn screening has been actually mandatory since 2006 in all 50 states and the US territory. There's about 2,500 babies born with sickle cell disease in the US each year. And as you can see from the map, the largest numbers are in Florida and New York, and with along the South where a lot of African Americans live. And then there's a void, in the middle Western states where there mainly Caucasians live in those regions. And I just wanted to do some comparison for you to get a perspective about genetic diseases and what the efforts are in the United States to find drug treatments and a cure. If you look at sickle cell anemia, which about 100,000 people are affected in the US, mainly African Americans, Latinos, American Indians, we have 4 FDA-approved drugs, 2 gene therapy treatments that just came approved in December, and about 35 clinical programs in progress to find more treatments, drug treatment, and gene therapy. For beta thalassemia, which is also a hemoglobin disease, but a different mutation, we only have about 1,300 of those affected in the US, mainly Mediterranean. They have a couple drugs, but they also have 2 gene therapies, and most of the research is done outside the US. But cystic fibrosis has been a main genetic disease that a lot of people have contrasted to sickle cell disease, but about 40,000 Caucasians affected in the US. But you can see they already have 8 FDA-approved drugs, do not have gene therapy, but have abundant number of clinical trials going on to find more treatments, and they're close to the gene therapy cure as well. And hemophilia is the other main genetic disease in the US, with about 33,000 mainly affect white males. They have 21 drugs that have been approved and 2 gene therapies, and several clinical trials are ongoing. So hemophilia has received a lot of attention from the pharma companies, but as you can see, there's some basically unbalance of the amount of research and treatments and development for sickle cell disease that we have to keep in mind as we go forward. So what is the problem? We talked about the mutation. We talked about how that affects the protein inside the red blood cell. So this cartoon shows you that here's the mutation, and when the oxygen is low, you get these strands that form in the red cell so that it goes to this from the normal shape to the sickle cell shape that causes a blockage in blood vessels. And because of that, the tissues do not get the oxygen it needs, and it leads to tissue damage or to actually failure of some of the body organs if it's severe enough and long enough. So what has been a very positive approach for treating sickle cell disease is from what we see in the first year of life. We know that children in their first year have high fetal hemoglobin and therefore do not have any symptoms when they have sickle cell anemia. But after the fetal hemoglobin, which is a baby type of hemoglobin, decreases and the adult hemoglobin or the sickle hemoglobin increases, we start to see the problems. So because of that, there have been many labs that have tried to research how can we turn back on that fetal gene to treat sickle cell disease. And in this cartoon tells you why. If you have only sickle hemoglobin, under low oxygen, you get the strand. But if you have 25% fetal hemoglobin and 75 sickle, guess what? It causes hybrids and you do not get the formation. So you don't get the sickle cell and you don't get the blockage. So it's a very effective treatment. And we know from the natural history study, which was funded by the NIH for about 20 years, if a individual with sickle cell disease has low fetal hemoglobin, their survival, shown here, is much less than someone who has higher fetal hemoglobin level. So we know from research and from studies that fetal hemoglobin is good. So there is effort, including in my lab, to develop more drugs that can increase fetal hemoglobin. We only have one drug approved, the hydroxyurea, that increases fetal hemoglobin and is very effective, increases survival, and it is the standard of care. 4 other drugs that increase fetal hemoglobin are under investigation. My lab was fortunate to be able to contribute to the laboratory and mouse work that led to the approval of these other clinical trials for the benzeroside, panabinoside, and AB1. And they're all in early clinical trials, and we're waiting to see if they are effective inducers of fetal hemoglobin. So we're excited that there are some drugs in the pipeline being developed. So what about curative therapy? So we talked about drug treatment, what the mutation is, what the problem is. So basically, your focus is going to be to try to take away the sickle cell gene or some way dilute the sickle cell protein. So in 1984, a young lady, a young girl who had sickle cell anemia and acute myelocytic leukemia, she received a transplant for her leukemia. And as a result of that, she was also cured from her sickle cell anemia. So that provided the first proof that bone marrow transplant could cure sickle cell disease. And with that, they formed a multi-center trial to look at what would be the outcome of individuals with sickle cell disease treated by hematopoietic stem cell transplant or bone marrow transplant, more commonly called. It was successful. In 1996, they published the work, and it quickly became, the standard for a child with sickle cell disease who had a suitable donor, which has been a problem. Only about 15% of children have what we call a matched donor and can use it for a transplant. It's a transplant. So now the research has increased to try to increase the number of donors that are available. And there's research now that shows that if you have a biological parent who has about a 50% match in the markers, or a sibling with 50%, that's good enough, that is actually suitable for a bone marrow transplant. So now these studies are being developed, and the opportunity has been expanded to adult patients. So long-term outcome, bone marrow transplant is about 90% successful in children, 87% successful in adults. Sometimes it doesn't take, they're not cured from the sickle cell disease, but it still remains a 5% death rate. So we still need to improve on the outcome. And worldwide, more than 1,000 sickle cell patients have been cured of sickle cell disease using a bone marrow transplant approach. So this is really, what the meat of what we're going to talk about is precision medicine and gene therapy. And where are we? Because if this approach is successful, then we don't have the problem of a shortage of donors. The individual can have their own cells actually altered and get what we call an auto transplant. So let's talk about gene therapy. And there's many approaches, but I'm just going to focus on 2 that are important and related to the new findings for sickle cell disease. So first, what is the definition of gene therapy? It's a treatment designed to modify the expression of an individual's gene or to correct abnormal genes to treat a disease. So again, it's designed to modify the expression of an individual's gene or to correct abnormal genes to treat a disease. So in the case of sickle cell disease, you say, well, why don't they just turn that one mistake, turn that T back to an A and be done with it? Sounds simple, but for years, people have been trying to do that, and it is very challenging to change that one nucleotide. So believe it or not, it's better to change bigger pieces of DNA than that one marker. So nowadays, there's 2 most popular approaches for gene therapy. The two we'll talk about is the lentivirus vector, where you add a normal gene. So in this case, we would look at adding a normal hemoglobin A gene with the sickle gene to make normal protein. And then the other approach that they've used for sickle cell is to use this new technology, CRISPR-Cas9, which you can go in and actually edit the DNA, and it can silence a protein that's actually turning off that fetal hemoglobin gene. So those are the two approaches that actually have been investigated the most. What happens when someone gets gene therapy? It's a very involved process. Not like you just go to their office and get a shot and go home. No, several steps are involved. First, you have to harvest the person's own stem cells from the bone marrow. And they're showing you a cartoon. These stem cells are the early cells that can regenerate all the blood cells in the peripheral blood. So you have to harvest the stem cells using this machine called the apheresis machine. Well, here you show the stem cells, and then here is the liquid part of the blood that's given back. And you have to do this 2 or 3 times to get enough stem cells for the gene therapy. Once the stem cells are collected, then they're transferred to a very specialized facility where they actually do the gene therapy, where they either go in and manipulate the DNA or add another gene. Once that passes the quality for clinical values and felt to be safe, then the patient receives a chemotherapy. So it is still like a bone marrow transplant, chemotherapy, and then they're reinfused with the modified stem cells that now has the new gene or silenced gene. And that leads to a decrease in sickling, the number of sickle proteins that are in the red blood cell, and then they're followed for another 10 to 15 years to make sure that the procedure was safe. We haven't been out long enough to know if gene therapy has cured sickle cell disease, because we're only about 5 years out from the first patient receiving the therapy. But we're very hopeful. So the first gene therapy that's been going on the longest has been where they add a new gene. Talked about the 2 approaches. In this case, they use the lentivirus vector. And yes, that is the same vector, the virus that carries the HIV protein. However, when they make it into a vector for gene therapy, they remove all the harmful proteins from the HIV and put in a copy of the hemoglobin A gene. That's what they're showing here. You don't have to look at all the details, but they put in a normal copy, and they keep the parts of the HIV virus that can help to put this piece of fancy DNA and help it to actually access cells or be taken up by the stem cells, because we know that HIV is very effective at infecting cells. So this allows them to put the DNA with the stem cell, and the normal gene is taken up. And the net outcome of that is you will block the sickle cell hemoglobin from making those strands, and the red blood cell shape will remain normal. So this was a very important landmark publication in 22 that showed this approach was effective. And it was very effective in sickle cell patients with this lentiglobin, or that fancy DNA construct that I just showed you. In the company that led that effort was Bluebird Bio. And this is just one image from the very important publication that shows you how effective the gene therapy treatment is. If they actually follow 25 patients long enough to evaluate them, and each one of these lines represent a patient. So you can see all of these little stars that represent the number of pain episodes and complications these patients had each year before the gene therapy. So you can see it's a lot. Once the treatment is given, shown here in the gray bar, look at what happens after the gene therapy, been followed for up to 3 years. Very nice resolution of the pain episode. We have a couple patients who still had some pain episodes, but they were much less frequent, okay? So they've continued to follow these patients, and this has been the case now up to 4 years that the pain episodes have resolved. And there have been no side effects such as hematologic or malignancy. So we're pretty sure that this is safe, but it'll take time to know for sure. So very effective gene therapy. Now, what is the second gene therapy that actually is being developed for sickle cell anemia and for beta thalassemia, which is another hemoglobin mutation, is shown here by a company called Vertex and the CRISPR company. And this approach is actually using the CRISPR-Cas9 to knock out a protein that silences the fetal hemoglobin gene. So with this approach, we know from genetic study, this protein called BCL11A is an effective silencer of the fetal hemoglobin gene after birth. So the reason, if you knock that protein out, the fetal globin gene will continue to be expressed. But the good thing is you only want to knock it out in red blood cells. So they found a way to do that. And when that was successful, they actually were able to perfect the gene editing to knock this protein out in red blood cells to increase the fetal hemoglobin levels and to block the sickle hemoglobin. And this just showing an example of the brief report that was published. It only involved a thalassemia patient and a sickle cell patient, but it was very dramatic, their response. First of all, they were able to get correction or silencing of that gene in their laboratory, and they were able to administer the gene, the corrected stem cells to a sickle cell patient and a thalassemia patient. And what they found, if you look here, this is before the gene therapy at the dotted line. And you can see after, this is the level of the fetal hemoglobin. It went up to almost 100% in every red blood cell. So it effectively blocked the sickle hemoglobin. And this is for the, this one is for the sickle cell patient, showed a similar response, high fetal hemoglobin. And this also eliminated the pain crisis in sickle cell disease. So subsequent results were released in the summer of 2023 that showed up to 35 patients with thalassemia and or sickle cell disease responded to the treatment. And these two reports became the basis for the FDA application to approve these two approaches for gene therapy for sickle cell disease and thalassemia. So this is the outcome. We're very excited. In December of 23, the FDA made the announcement that both the gene addition gene therapy, that's called the Lyfgenia, and the CRISPR-Cas9 gene editing, they were both approved on the same day. So now there are options. Which one is better? Which one is safer? We don't know. The gene addition work has been going on longer. But there are still some concerns and things that we have to continue to watch for a few more years before we can say that there are not going to be any bad side effects from doing this manipulation, especially of the DNA using the CRISPR technology. So we're excited that we have this, but we're continuing to develop more drugs because this won't be available even in the United States to everyone. A lot of issues and things to work out. So the NIH had already saw that the drugs are gene therapy was going to be approved. So they really made an effort to put money into looking at a cure for sickle cell disease. And that, I think, is what really prompted the rapid movement to get these drugs approved. And what they are able to do is pump $100 million into the research community to increase research related to a cure for sickle cell. So it's ongoing. These two are just a start. Other labs are looking at other ways. And I was fortunate to be part of a team that showed, we looked at a model to try to determine how would gene therapy affect the individual. We saw that it's good for the individual, the family, cost, impact of work, and education. And what we found was gene therapy will substantially increase life expectancy and the quality of life of sickle cell patients. Extending from the payer point of view, so insurance to societal importance, is basically an increase in productivity for individuals with sickle cell disease, their families, their caretaker, the cost. But kind of the eye-opening part of it is that it's going to cost about $2 million to actually pay for gene therapy per person. The one where the gene addition is actually almost $3 million, it's projected. And the CMS with the Medicaid, it actually will decrease by almost $3 billion if 1,000 patients with sickle cell disease get a gene therapy treatment each year. So it's a lot to look at. And I look at, we'll be able to save money and improve the quality of life of individuals. So I'd like to just close by saying we're not there yet. We still have other issues to address. We need to look at cancer risk. We need to look at the off-target effects of the DNA modification with CRISPR. We need to look at access to gene therapy, even in the United States. Will all patients have access? The cost, and then in the future, looking at better ways to give the gene therapy without the chemotherapy, and look at other approaches that will be less toxic and less time consuming. Ultimately, we would like to be able to make the gene therapy where you could just go to your hematologist and get a shot, and that would be all you would need it to be cured of sickle cell disease and other genetic diseases. So I'd like to end there, so that we can go on now, I think, to a good discussion about the ethical issues related to genetic treatment. And I'll turn it over to Dr. Sodeke. Thank you.
Thank you so much, Dr. Pace. Outstanding presentation. Now presentation, that's a tough act to follow. By the way, but my own presentation is going to be mainly conceptual. I am a bioethicist. I shall remain one, and so that's the sense in which I approach this conversation here. 2 slides contain the articles that I used to make get ready for this presentation. 1 of 2, 2 of 2. And I thought that I will give you a roadmap of what I'm going to do. That is to help you think along with me. The idea of bioethics conceptually, in terms of being given a very broad definition of it, because that's what will work for me to be able to discuss the ethics of the sickle cell disease gene therapy, and also discuss the ethical, social, economic considerations of it, as well as some suggestions for future direction. So that's how we are going to go. Way back when, we had these definitions way back since 1971, maybe even before that. We have various definitions of bioethics. Van Rensselaer-Porter out of Wisconsin has it as a new discipline that combines biological knowledge with knowledge of human value systems. But by 1972, it has evolved into the study of ethical dimensions of medicine and biological sciences. And I would say many people still hold on to these definitions. And then by 1972, and perhaps a little bit beyond, the discipline at the intersection of science, medicine, and ethics. Bioethics since then, of course, has evolved a lot. When I took a look at this, after studying the definition and the what it means, I came up with the idea after about 10 years of studying, that perhaps what we need to do is to look at the word itself, etymologically, philosophically, and operationally. Etymologically speaking, bioethics is a compound word. The first three letters that there, bio, comes from the Latin word bios, which means life, and ethics is the rightness or wrongness of actions. If we define it philosophically, it is ethics in the service of the bios, in the service of life, all life, animal, plants, and humans. Insofar as humans is concerned, we mean ethics in the service of a full life, economically, socially, culturally, and yes, religiously as well. If we look at the operational definition, it is the critical examination of the moral dimensions of life activities. I say that again. Critical examination of the moral dimensions of life activities. So if we pull all of these together, we will see that bioethics actually is what brings ethics into life and life into ethics, given all the elements that I've talked about. So defined broadly then, bioethics is the discipline that identifies, helps to determine the rightness or wrongness of actions in life activities and on being and the morally responsible thing to do about them. In terms of practice, so far as even teaching is concerned, and I do teach bioethics, with the use of ethical theories and principles, the teaching and learning bioethics involves logical analysis, leaps of imagination, telling and narratives, trading, storytelling, reflecting, remembering, deliberating, and, if you will, deciding as well. It involves the ability and a willingness to query action. So all of the decisions that we have made so far in terms of sickle cell disease, the different kinds of therapy and treatment that abound now are open to different kinds of questions. And I'll get in a couple of slides to what those questions are like. We need to be able to query actions, to scrutinize issues in actions by discussing and deciding. What this does, it enables us then to gain moral sensibility and develop sensitivity to the chasms that may be out there, so that we can inculcate what we call bioethical maturity that's needed to provide us with appropriate policy and law. This is a summary of all that I have said so far. It involves identifying and addressing ethical, social, religious, legal issues that arises in the field of medicine, research, public health, environmental health, science that we've heard so much about, nature, and of course, technology as well. So if you can think about bioethics as an umbrella term, that's why I like this slide, because it captures the whole thing. I put this slide there to pay homage to a friend of mine, Dr. Carlton Haywood. Some of you might know him. He was a sickle cell patient, sickle cell disease patient, lived from 1976 to 2021, an outstanding researcher, very resilient. He's a trailblazer, if you will, and a very inspiring person. at that. Dedicated to health equity, he's an advocate, was a bioethicist himself. He served as assistant professor at Johns Hopkins School of Public Health in Baltimore. So I thought I would pay homage to Dr. Haywood that way. Some of the articles that I used in preparing for this presentation actually came from him. There are three principles that anyone who wants to talk about bioethics should be familiar with. And this came from the Belmont report. The Belmont report came out of all the series of hearings after the syphilis study was halted in 1972. In the Belmont report that came out in 1979, these four principles were outlined there. Principles of autonomy, beneficence, non-maleficence, justice, fairness. The practical application of each of these principles, for example, autonomy is ethical informed consent process. And I cited an article there. Beneficence, do good. That means that we need to weigh the benefits of all of these therapies against the risks of them so that we can be sure that patients are benefiting as well as their families as well. Non-maleficence, do no harm, of course. So that means that we need to be mindful of the risk or harm that may be present so that we can mitigate it. There's a citation there as well. And of course, fairness, justice as fairness means equitable distribution of benefits and bodies, fair treatment and maintenance of care. It also involves interdisciplinary collaboration of researchers. Dr. Peace alluded to how folks are collaborating, clinicians are talking, but the affected communities need to be involved as well so that they can co-create useful knowledge. There are ethical, social, and economic considerations, as I've indicated. Dr. Peace mentioned some of these. There is a worry about accessibility and affordability. These are not cheap therapies. They're still very, very expensive. So one is worried about equity and justice. The question that was at the back of the topic that we are addressing is who benefits? Well, one could say perhaps people who have enough money to do these, who can afford to do that, spend that kind of money. Of course, there are other therapies that are not as expensive as the gene therapy. Equity and justice in terms of fairness, being sure that we inform the patients accordingly. These are not simple instructions. These are very complex information. And I'm sure Dr. Peace is very familiar with this. This is in fact necessary so that personalized choices can be made, particularly when alternatives are there. It needs to be transparent in saying that. I put stigma and identity there. We talked about pain and what it does and how even individuals are perceiving themselves, let alone how the healthcare system is perceiving them as needing pain medication, even as maybe drug addict, instead of listening to them and seeing their condition for what it is. Cultural sensitivity is very important for the community so that we can engage them appropriately. Dr. Pace mentioned quality of life of the adults. This is important as well. Impact on patients and families. Everybody knows that whenever there is a serious illness like this in the family, it is not only the patient that suffers, the family suffers along with the patient as well. Our healthcare system and the policies that need to be in place, we need to be aware of that too. As Dr. Pace mentioned, some of these, I'm glad more money is being poured in this direction now. And if we discover something and it's useful here, it has global implications as well. I put workforce participation impact there as well. I showed you the picture of my friend, Dr. Haywood. He was very energetic. He stayed in the workforce, outstanding researcher. So there's a lot that can be gained if we spend the money that is necessary to develop these new drugs. Of course, educational attainment of those affected, he is gone now, but then there are others who are going to continue the fight as well. Future directions I put in there, and Dr. Peace kept alluding to it. We're not there yet. There is still more work to be done, which is great. I'm glad to hear that. Improving efficiency and efficacy of the drugs and the safety of it is of concern as well. And we need a lot more work on that. Alternatives, of course, need to be in place. Collaboration, we cannot say too much about that. And then, of course, there are all these ethical imperatives, quality of life, emphasizing collaboration, looking forward with optimism. My friend, Dr. Haywood, was so optimistic. He submitted himself to several clinical trials and leaves a lot of things for us to think about and to gain. I think the way things are looking, the future of gene therapy is really bright, and we are going to do more for sickle cell who happen to be stricken with sickle cell disease. Thank you for the opportunity to make this presentation. And here are some people that are still keeping the fight going. General Stevenson, some of you may be familiar with her. What she wanted to do was run. She underwent gene therapy and now no pain in 6 years. This is to corroborate what Dr. Pace just said. And now this young fellow here, Johnny Lubin, is one of those that's still keeping on with the fight. So I think this is my last slide. Thank you so much.
Thank you, Dr. Sodeke and Alice.
Hello, everyone. I do not have slides prepared. I was told I would only have 10 minutes, and I don't know where to begin. But since we're on the topic of gene therapy and sickle cell, I just wanted to talk a little bit about my most recent journey of going through gene therapy in a clinical trial. So just this past October, I was admitted into a hospital. I got a good chunk of chemotherapy, and then I was given my stem cells that were retrieved after Dr. Pace gave a good representation of what I had to go through to get those stem cells. And after going through the initial rough symptoms of chemotherapy, I started to develop fetal hemoglobin. And since then, I have been pain-free. I have not had a pain crisis, and I have been more energetic. Just overcoming fatigue has been a huge blessing. And there are still some struggles, you know, having to travel back and forth specifically for this clinical trial, and also enduring pain of damage that had already occurred. So in my case, avascular necrosis is something that I was diagnosed with as a result of sickle cell anemia. And unfortunately, the gene therapy doesn't reverse avascular necrosis, but I am undergoing some physical therapy, and there are other options for me to kind of relieve the pain that is kind of lingering from those things. So I was hoping this would be more of an open kind of Zoom meeting, not necessarily a webinar, because I was really looking forward to kind of letting the audience guide what they want to hear from me and what they'd like to learn. If anyone has anything to add into the Q&A or any questions they have for me as a sickle cell warrior who has recently undergone transplant, or anyone who's considering gene therapy, if they had any questions for me, I definitely would be willing to answer anything that anyone wants to know. I didn't want to repeat what was already presented, but I did have a lot of background going in as a scientist, getting my PhD in molecular medicine. I actually understood the science of the clinical trial, and the doctors were really annoyed with me because I was the only one who was asking all these complicated questions. They normally deal with pediatric patients. So to have someone ask these high level questions, they're like, oh, wow, you actually know what we're talking about. But yeah, it's been very interesting, and I've been very blessed to be involved, not only intellectually, but just being, I guess to say, being a guinea pig, because I know there's a lot of history there of, you know, being hesitant to participate in research. And I personally, although there was some hesitancy, I felt comfortable not only knowing a lot about the science behind it, but also just how things came together on a personal level for the timing of this clinical trial, and just having everything feel right, so to speak. Let's see, I am monitoring the Q&A, so let me see what I could read here. Okay, so this, Juan, hi, Juan. He asks if my family was worried about the outcomes of the trial and if fear played any role in my decision and process. So my family was actually very optimistic and hopeful about the outcomes, like probably more so than I was. I still had a little bit of hesitancy, but they were just so ecstatic, especially my dad. It was almost heartbreaking to realize how much my dad had sacrificed, just not really knowing exactly what to do anytime I was sick. He was always the one to fly out if I was out of state. And my mom too, she sacrificed so much, staying in the hospital with me. So I can understand how they were super ecstatic as opposed to me, who was like, I don't know like what my future is going to look like 10 years from getting this therapy. But they were very, very optimistic and thankful for this opportunity. Personally, I wouldn't necessarily say that fear played a role, but I was a little hesitant just because with any clinical trial, there's a lot of unknowns. But what I was able to kind of hold on to that helped me overcome that hesitancy was just learning more and more about it, one. And two, the fact that there had been success stories already for this clinical trial. So a lot of you know that 2 of these gene therapies have been FDA approved, and I'm actually in a clinical trial that's very similar to the CRISPR-Cas9 gene therapy. So knowing that there was similar research already published on the clinical trial that I was signing up for, that helped me overcome any kind of fear or hesitancy that I was feeling initially. Renee Kirby, hi Renee. I would like to know, when do they consider you cured? And cured is in quotation marks, as it should be. A lot of people like to consider this a curative therapy because it's not necessarily a cure. I usually say that I technically still have sickle cell. Like if you took my genes and like sequenced them, you'd still see the mutated hemoglobin there, but I have increased fetal hemoglobin that's helping to offset the negative effects of the sickle hemoglobin. So I technically still have sickle cell, but I've been told that this curative therapy kind of kicks in at full force after about a year. That's the general timeline I've been given, and that's mainly recovering from the chemotherapy side effects. That's my understanding. No one told me that, so don't quote me on it. But my understanding is that the reason they say a year is because not only are you building up your fetal hemoglobin and kind of recovering from this whole operation, but you're also recovering from the lingering side effects of chemotherapy. Okay. Ooh, Dr. Lori Banks. I know everybody. So she says, if you are comfortable speaking about it, what is the cost like? Is this widely available now, or is that on the way? Ooh, that is a loaded question. I have no idea. I know the recent FDA approved gene therapies had a huge price tag on them in the millions. I can't remember the exact cost, but no one has that kind of money. So I really, really do hope that as these clinical trials continue and as research continues, that price does decrease, because there's no point in having these amazing scientific discoveries if there's no way to access them. So I can't speak on the pricing or the costs of these therapies, but I really do hope that in the future there's a way to make it readily available for anyone who needs them.
Alice, include at least the cost right now to you.
Oh, to me, of course.
Yeah.
So that's another thing that I'm very thankful for. Because this is a clinical trial, I don't have to pay out of pocket for anything. I'm reimbursed for my travel and for any expenses related to the trial. So that's another thing that I'm very thankful for, is that I was able to be part of this clinical trial without having to worry about the cost after the fact. I'm sure that there are still trials ongoing that have that incentive. I don't know of any specifically, but I feel like that's a good trade-off, at least for me. Like, I'll be a guinea pig if I don't have to pay for anything. But yes, for me, thankfully, I didn't have to worry about that cost. So this question from Julia, are there any specific communication shared with you that allowed you to take the next step to start therapy? And or is there any communication advice you could give to other patients who are not as knowledgeable on treatment options? I would say just ask questions. There are no stupid questions. Don't be afraid to ask them. Even if you don't know how to word or phrase a question, you just start. Because even me, I had the scientific background, but I didn't have the background in like genetics and gene therapy. So I was asking lots of questions. Thankfully, I had amazing doctors and a great team. They were all very friendly and willing to answer any kind of question I could come up with. So if you are considering gene therapy, I'd say just ask a lot of questions. Ask the doctors, ask the nurses, ask any of the staff that are involved in the therapy, and even ask questions outside of the clinical trial workers, because of course, anyone involved in the clinical trial wants you to be involved. And so you want to ask others if they might have some background, just a little less bias. But I feel like that is what helped me, is just kind of knowing what I was getting myself into and being very thorough about the questions that I was asking, all big or small. Let's see. So does it limit the amount of hospital visits and need for transfusion or blood work? Absolutely. Blood work, I'd say, is still kind of iffy, just because I am part of a clinical trial. They're collecting a lot of blood to make sure that they get the data they need. They know where my counts are. They can monitor that very closely. But I have not been in the hospital since I was discharged from gene therapy treatment, and I have not had a need for a transfusion since then. Of course, I'm very new to this. It's only been about 4 months since I received my transplant. But I have heard from others who received it as far back as 2-3 years ago that they have not been in the hospital since. So it's an amazing transformation. let's see. Did you feel like the organizers of the clinical trial used effective scientific communication that was culturally competent during the recruitment process and throughout the trial? During the recruitment process, yes. The way I found out about the clinical trial was through a local organization known as Sickle Cell Mark Thomas Foundation of Texas. I think I said that backwards. Mark Thomas Foundation. So they had Dr. Frangel come in with his first patient, which was Victoria Gray. I don't know if any of you know those names, but they came in together to kind of talk about the clinical trial and talk about some of the outcomes of the trial that occurred before I joined. And I felt like they used culturally competent language during that. I was able to understand what exactly they were doing. Of course, it's hard for me to say, having that scientific background, I feel like I pick it up on it easier. So it's hard for me to say whether someone who didn't have a scientific background or more of a lay person would have understood as easily as I did. But I personally feel like they did communicate effectively. And I also feel like they would have adjusted based on my competency, like just based on the questions that I was asking. There are some times where they would, say things in simple terms, and then I would ask them to elaborate. And so they would kind of increase the difficulty level so that I could kind of absorb it a little more. I hope that answers your question. Let's see. I don't know how much time I have. There's still a few more questions.
I tell you what, the next two, let Dr. Pace address them, and you can read down to Renee's, but let Dr. Pace answer these next two.
So
Okay.
first, I'd like to say thank you, Alice. That was very, very insightful. Since you've gone through the process, it sounds like you actually got the Bluebird Bio gene therapy with Dr. Frango, so I know him very well. So that's exciting because the clinical trial is continuing. One other thing that's important is that they're looking at younger children. Your comment about not being able to reverse the complications is very important, because if you can do the gene therapy early before organ damage has occurred, then you have a better outcome. So they are now looking in the clinical trials to treat pediatric and younger patients, which is good for me because I'm a baby doctor, I'm a pediatrician. So very excited that they are going to look at children. The question about cure, and I will answer the chat question, we consider a cure for either transplant or gene therapy after, or even cancer, we say 5 years. So we have a ways to go. We have not, there have been some patients that have been 5 years out, but we don't call it a cure after the gene therapy. You have to continue to watch and monitor for up to 5 years. And then one other comment I would make is about your stem cell. With the gene therapy, when they take out your stem cell, that's in your bone marrow, that is what is modified, only those stem cells. But your germ cells, your eggs, sperm, those still have the sickle cell mutation, and that can still be passed on. So only the patient is cured, only the genes of your bone marrow cells are changed, but the rest of it for inheritance, genetics, that remains the same. So everyone would understand that. So off-target effects, I didn't go into a lot of details about it, but it's a concern for both. When you add a gene or the CRISPR-Cas9, I think there are bigger concerns for the CRISPR because you're going in with these specialized proteins and kind of chopping up the DNA and taking pieces out and putting it back together, where there's a lot of things that could go wrong. Or what if those specialized protein go to the wrong gene or knock out an important protein? So that is just going to take time monitoring. There are ways they test for that. And so far, there have not been anything that suggests there are off-target effects from the CRISPR gene therapy for sickle cell disease, where they increase the fetal hemoglobin. So we're very positive at this time that there won't be, but we have to continue to monitor. The next question is, what is the hypothetical impact of this therapy on women of childbearing age, specifically in terms of passing along sickle cell disease? Oh, very good. After therapy is complete. That sort of gets that what I was saying about the stem cell being changed. So even childbearing, now the actual gene therapy itself, it only affects the stem cell, but I may be getting at what are the effects of the chemotherapy. That is really where the concern is for someone of childbearing age, because you still get chemo before they give the modified cells back, and that can affect your ability, your fertility, and ability to have children in the future. So there are many programs where they harvest the eggs, if it's a man, the sperm, and harvest for someone of childbearing age so that they can at least have the option to have children later. But as far as the genetics of it, the individual who gets gene therapy still can pass on the gene to their children. So that's the difference between that. So very good question. Look like there's a question about the personal physician.
Yeah, I think that's Alice's. And there's one for you from Jawan down at the bottom.
Yeah. So the team did work with my personal physician. It was more of at my request, but the offer was always there. So they asked for, well, I wouldn't say it was at my request. I requested for more interaction, but they work with your local hematologist to make this work. So they would have your local hematologist's information, because they have to coordinate exchange transfusions that kind of keep you healthy while you're off of your normal sickle cell treatment drug. So I had to be off of all my regular medicational regimen for this trial. So they work with my local hematologist to make sure I'm healthy, to make sure I stay out of the hospital, make sure I'm not, suffering while they go through the process of stem cell collection and fertility preservation and all the things leading up to this trial. And I feel like the team that I worked with was definitely supportive, not only then, but even now ongoing as they continue to monitor me. Both the team here in Tennessee and my local team back in Tucson, they are both supportive and making sure that I have what I need. Let's see. Aside from the annual Sickle Cell Warrior Convention, is there another platform that speakers like you share their stories about the trials and therapies? I don't know. I hope to have more events like these to be able to share. I would say events similar to the Sickle Cell Mark Thomas Foundation of Texas would be the place that you would likely hear things like this, where you'd get on a more personal level. I don't know any other example I could think of. It's more of a it's more of a professional setting where they're just presenting the research of the clinical trial as opposed to presenting a patient who's gone through the trial. But there are events similar to the Sickle Cell Warrior Convention that focus on sickle cell. There's actually one coming up where Dr. Frangul is going to be presenting. So the doctor that headed my clinical trial, don't remember the name of it, but I will look very quickly. It is the Foundation for Sickle Cell Disease Research, and they are having an upcoming symposium on June 7th to the 9th. So events like that, I feel, would be places where hopefully patients can speak about their experiences more often.
Yes, I think you're right. I attend that meeting every year, and they really always have a very strong patient component where you can tell your story, experiences. Also, the Sickle Cell Disease Association of America had their meeting in the fall, and they always have a very strong patient component for that meeting as well. So both of those are actually very good meetings to get the perspective from patients, which is important. And I also would say that you had the quote unquote perfect condition to get your gene therapy because it was part of a clinical trial. So everything is paid for. People are really, organized. They get protocol. They do it step by step. That is not what's going to happen in real life. when it becomes available as a drug treatment. So we'd have to keep that in mind. We haven't made that transition yet. The new drugs that were FDA approved, they're still treating patients under clinical trials. So when it becomes available to the public and we transition, we may start to see more issues related to, the good question about them reaching out to your local hematologist. This has been a big problem in the clinical trial. They're not reaching out to your general hematologist because they're the people who are going to take care of you long term. You'll end up going back to them. So these are issues that we are seeing and hopefully will be addressed as we move forward.
So I wanted to jump in real quick because we want to end at 8:15, and there's one more question, Alice, if you just answer her so that everyone can see the answer to it from Megan. But to answer Mina's question, we do have recordings that are available. And V, could you put the link in the chat for us, please? But if you go to the website, we're at Baylor College of Medicine, that's bcm.edu. We are in the Molecular Human Genetics Department. Okay, so she has it up. So all of the recordings are there for Evenings with Genetics. And you will see the recordings for the Black History Month edition. So this year we focused on sickle cell. Take a look at the other ones that we've done. I think you'll find those with a lot of information that's useful for sure. Maybe give us a month before the recording goes up. It does take a little while before everything gets edited correctly before it goes public. But we will have that. And you can always reach out to any one of us. But I wanted to take this time to thank our speakers. This was just absolutely fabulous. Dr. Pace, oh my goodness, it's just wonderful to hear about all of the work that you've done. And Dr. Sodeke, and I know I should have asked you to give us a little of that Tuskegee history, because I know anybody who saw your name were like, oh, wow, he's going to talk about that too. Like what from the Tuskegee side. So we might have to bring you back to come with a different approach to it. And then Alice, we thank you so much for sharing your story, because it really makes it real when you have someone who's going through it. And as Joanne was asking all of those questions, I had a couple of that we needed to elevate him up so we could really have a good discussion between the two of you. But I think you can create your own space where you share these stories and find other people like yourselves to do this kind of forum, because it is important. And especially now with all of the changes based on therapy and lack of money, or the abundance, if there is such a thing. But now we have a cure, but nobody can use it. That's what it seems like. So yeah. I want to thank everyone. We give you hand claps. Yeah. And so happy to have everyone who was able to attend. And please join us again for another Evenings with Genetics. Thank you so much.
Thank you. Thank you for inviting us.
Thank you so
Bye-bye.
much.
Lovely to meet you, Alice.
Thank you for inviting us.
Thank you.
Thank you.
Thank you, Alice.